Hello and welcome to the channel. This is Dr. Prashant Shukla and yet another interesting case I have come up with. This is a young patient about 40 years and he presented to us with this anterior subcapsular cataract with anterior subcapsular fibrosis, and we have planned to implant a Magnificent intraocular lens from Care Group. Well, no financial interest though. And the other eye was absolutely normal, there was no cataract, so I was suspecting a traumatic cataract because he was giving some vague history of injury to his affected eye. By this time, the anterior capsule has been already stained using trypan blue and viscoelastic has been instilled into the entry chamber. And now I'm going to make the main phaco incision. It would be a triplanar incision using a steel keratome blade. Here I am using a 26 gauge bend needle cystitome to create a flap, as I would always want to encompass or say bypass the subcapsular fibrotic area, and I am planning to have a nick somewhere around the fibrotic plaque because the fibrotic plaque area is not very big, about 3 to 3.5 millimeters, and I feel I can have a very good capsular access all around this fibrotic area. But the main point is to have a small opening so that it can be held properly. So now, using Dr. Haldipurkar's capsular access forceps, I am initiating the capsular access. And I'm also taking the subcapsular fibrotic area along with the moving rhexis. With 2-3 grabs of the capsule, I could complete the rhexis, which is fairly round, central, size about 5 to 5.5 millimeters. Because I am also expecting a weak posterior capsule in this case because I feel it is more of a traumatic cataract. So I need to get the rhexis size right. Gently burping out some of the viscoelastic and doing a gentle hydrodissection. The nucleus grade is relatively soft as he is a young patient, and I am planning to prolapse this nucleus one pole out of the capsular bag. So again I am injecting small amount of fluids till the one pole comes out. Because in these soft cataracts, many a times we end up having a bowel, so it's always a good idea to just prolapse one pole out of the capsular bag. Some more hydrodelamination is being done. Some viscoelastic is instilled in front of the nucleus, some behind to protect the posterior capsule. By injecting some viscoelastic behind, the posterior capsule goes back and there is vague chances of catching it. So now the phaco handpiece has been introduced into the eye with power about 40, vacuum about 300, bottle height about 100. The nucleus is relatively very soft and I am planning to just emulsify the whole nucleus as a whole, and gradually the phaco is emulsifying the nucleus with moderate power settings. just as shown. So always good idea to prolapse one pole, because if we have a bowel formation, then things become slightly more difficult. In this case, I am not using much of power, it's more of an aspiration which has been used. The endothelium is well protected by the viscoelastic, and here I am using dispersive viscoelastic to protect the corneal endothelium. So some epinucleus is now left, and within a moment the remaining epinucleus shell will also be emulsified. I am going really slow, not using very high power, because I don't want to have any chattering of any of the nuclear pieces, which would just go and hit the corneal endothelium and lead to corneal and endothelial cell loss. So here it is. Now is the time to remove the cortical material. Here I am using coaxial irrigation and aspiration. Vacuum now is about 350, bottle height about 110. This is a venturi based system. We don't have to monitor the flow rate. The machine automatically manages the flow rate. So first the subincisional area is cleaned up. The cortex is gradually stripped off from the equator. I avoid vigorous pulling of the cortex. It's gradually nudged out with slow movements, and once we have a good hydrodissection, there is not much of a problem to remove any of the cortex. So now I am towards the end of the cortex removal. The whole bag is very clean. As can be seen, PC is intact, and now is the time to implant the intraocular lens. Here I am putting cohesive OVD to form the capsular bag, and the lens has already been loaded. Some visco is just sprayed over the corneal surface just to aid in visualization and avoid any corneal dryness. This is a very nice lens. Just a moment, it's going to unfold, and the beauty of this lens is it can be identified by two holes, which are probably the dialing holes at the junction of optic and haptic on both the sides. This is a slightly bigger lens, so one has to get used to the loading technique. This is the dialing hole I was talking about. So got two holes, and one can identify this lens by these holes. Now the whole lens is in the capsular bag, well supported, well centered, and now I'm going to remove the viscoelastic from both posterior and the anterior part of the intraocular lens. So the viscoelastic from behind the intraocular lens has been removed now, and now I'm going to just reposition the intraocular lens with the same IA handpiece, and I'm going to remove the viscoelastic from the surface of the intraocular lens and from the anterior chamber. Purposely I am taking some time because I don't want to have any post-operative IOP spike in these cases. Vacuum now has been around 450. Bottle height is about 120, and almost all the viscoelastic has now been removed from the eye. and in a moment I'm going to come out and close the incisions. So now I'm going to hydrate the wound. Some moxifloxacin goes in, and I'm going to hydrate the main incision, first the roof and then the sides. The patient did very well, and after about a month post-op he could read 6/6 partial without any correction and N8 with this operated eye, and he was very happy. He could use his mobile phone without any need of any spectacles, and for very fine work we gave him some near addition, and hopefully this video is going to help you. Please do like, share and subscribe my channel, help the channel to grow, and keep following for new updated videos. Thank you so much. Have a nice day.